Hi guys, this is Rapid Ophthalmology and you are studying with me, Dr. Nawaz. So let's speak a little bit about orbital pathology. Before we begin with orbital pathology, I think it's important to look at a few of the salient features in orbital pathology. You have proptosis and then exophthalmos. Proptosis is referred when any organ in the human body protrudes or gets proptosed, so to speak, whereas exophthalmos is specifically for the eye. Now looking at this diagram, this is a fairly common presentation in cases of orbital pathology. Here you can see there is some conjunctival injection that can be seen, whereas in this area you can see that there is edema in the conjunctiva, which would be called as chemosis. Speaking about proptosis, there are two types of proptosis: an axial proptosis and a dystopic proptosis. An axial proptosis occurs when you have an intramuscular conal lesion, which means if this is the eyeball and these are the muscles, if you have a lesion in the area inside of this muscle cone, you guys should remember that the eye basically looks like an ice cream cone. So this is the cone, and if there is a lesion within the cone over here, it pushes on the eye from behind and the eye goes forward. Whereas if there is a lesion, say a lacrimal gland tumor, now we know a lacrimal gland tumor is superolateral in position, so that would push the eye infero-medially. So this would be called as a dystopic proptosis. Always keep in mind to measure the horizontal and vertical displacement while documenting a proptosis. The severity of proptosis can be measured with the help of an Leeuward's exophthalmometer and also a Hertel's binocular exophthalmometer. You should measure the proptosis in a relaxed and with a Valsalva maneuver to see if there is a variation. Enophthalmos is when the eyeball has recessed into the orbit, the opposite of what an exophthalmos is. Now coming to ophthalmoplegia, restricted movement of the eyeball could be characterized as an ophthalmoplegia. Whenever a patient presents with ophthalmoplegia, you're supposed to do a forced duction test to find out whether the ophthalmoplegia is due to a paralytic origin or whether the muscle has been captured. So if there is a muscle capture, you would understand that the eye would not be able to move either medially or laterally even when you hold on to the conjunctiva with a pair of forceps. This is a fairly painful procedure. This is supposed to be done in the OT. You don't do it on any patient. So this is done in a locally anesthetized eye. So if you can feel that there is movement in the eye when you've used forced duction, then that could prove that this patient has a paralytic ophthalmoplegia. Whereas on the other hand, if there was a muscle capture, so no matter what amount of force you would put on the eye, you would feel there is a certain resistance to the movement. So that would help you distinguish between a muscle capture and a paralytic ophthalmoplegia. Then coming to the differential IOP test. A differential IOP test In the gaze in which the movement is restricted, if there is a variation in the IOP in the region of 6 mm, then that is called as a Braille's sign. Sometimes proptosis are accompanied with pulsations. These pulsations are best monitored with the help of a slit lamp. In the applanation tonometer, which is generally used to measure IOP, but in this case, the sensitivity of the applanation tonometer will sort of pick up on the tiny pulsations that may be sometimes associated with proptosis. Can anybody tell me which condition would you see a pulsatile proptosis in? Please comment below with your answers and let's see who gets the right one. Then we have an increased venous pressure, which would again be characterized as a conjunctival chemosis or a conjunctival injection. That is how an increased venous pressure manifests itself. Then you would also have a bruit that is sometimes associated with the proptosis. This can be seen in conditions such as CCF, and this is examined with the help of the bell of the stethoscope. So keep these things in mind. What sort of changes would you be expecting to see in the fundus? I mean, we are talking about an increased pressure here sometimes, and that could lead to optic disc changes. So a disc swelling, which is very fairly characterized here in this diagram as the blurring of margins, is something that happens before you have an optic atrophy. So always remember, the optic atrophy comes secondary to a disc swelling. So if you look at an optic atrophy, know that this is not a recent onset. This has been there for quite some time. Then we have optociliary collaterals and choroidal folds. So essentially there are some things known as collaterals that do characterize themselves as new vessels, but these are actually beneficial to the patient's retina, and whenever you have collaterals coming in, it basically signifies a good prognosis. This is not a hard and fast rule, but generally it signifies a better prognosis for the patient. So collaterals, we like them, whereas neovascularization we do not. And then you could have something called as a choroidal fold, which could basically be seen in the back of the eye. As you know, there is the choroid behind the retina, and when there is increased pressure, sometimes the choroid gets wrinkled, and that high pressure wrinkle sometimes show themselves on the retina also. Some investigations that can be done when you have an orbital pathology presentation are a CT scan, which are mostly done to test for abscess and bony lesions. MRIs are generally done only if we suspect a thyroid eye in an X-ray in the case of orbital pathology. And then an ultrasound could also be ordered. An ultrasound generally is not very good to visualize the orbital apex. Then we can order for a fine needle biopsy. These are generally done for neoplasm. So now going over some points that have some importance regarding their high yield in the tests, especially in international exams, as I'm also preparing for one. Pain is present. Graves' disease is usually not the cause of the orbitopathy. Graves is usually a axial proptosis, whereas lacrimal gland malignancies and maxillary sinus tumors produce a dystopic sort of proptosis. A pleomorphic adenoma presents with a proptosis that is long-standing, which helps it distinguish from other types of proptosis that are generally very early in onset. Children's orbits So children's orbits are more plastic. So disorder with a short duration can actually cause an orbital enlargement in children, whereas this is not the case in adults. Now, proptosis could sometimes cause a superficial punctate keratitis. The patient has a diplopia in upgaze. You could actually think about an orbital floor fracture. So the most frequently involved muscle in orbitopathies are generally the inferior rectus. This can be remembered with the mnemonic I am Stuart Little, I for inferior, M for medial, Stuart for superior, and Little for lateral, in order of their respective involvement. Another thing we could look at is the most common cause of bilateral proptosis in children is not definitively established, but you could have a metastatic neuroblastoma and or leukemia. And what about the most common cause of bilateral proptosis in adults? It's the thyroid eye disease. What about the most common unilateral proptosis? That's again the thyroid eye disease. Whereas in children, the bilateral proptosis would be metastatic neuroblastoma or a leukemia can be considered. So now, moving on. In pediatric autoimmune hyperthyroidism, the systemic findings are more prominent as compared to the orbital findings, which are less common and less severe. The upper limit for normal exophthalmometry in white men, Caucasian men, is 22 millimeters. This is also an important parameter to know. And this is how you generally assess the severity of the orbital pathology. These are some of the soft tissue features that are associated with orbital pathology, and then the accompanying severity grade. Some features such as chemosis, conjunctival injection, lid edema, pain at rest, pain or movement. These are all graded with a possible score of 10. So this is not really done on every patient, but knowing how they are generally assessed is a handy tool. So guys, that was the topic for the video. Please do your comments and leave some feedback. I read all of them. And the stamp for this video is of course the 19th Ophthalmology Congress held in New Delhi. This is a human eye within a lotus blossom. I love ophthalmology related stamps, courtesy mrcopts.com. And guys, if you like my content, please do consider subscribing. And also I will have my Patreon account up soon, and consider subscribing to my Patreon also. Please do share and take care.